This talk is going to be about the importance and the basics of the lights, the standards, and how our eye lens is changing with the age, the sources, mounts, and the distinct features, and some of the other aspects of how the normal light should be in the theater, accessories, and some aids, and also some relevant publications, and my idea of future light. So it's very important that the light should be able to give you and identify all the structures, and it should avoid iatrogenic injury. In a small instance, you should be able to do when you have got a good illumination, and of course you have to minimize the hazards. Regarding the basics, it has to have an adequate contrast, shadowless, focused with a desired range of illumination, sterilizable electrically, and operationally it should be safe. And it should be having a reliance of ease of maintenance, and it should not obstruct the laminar airflow. Ministry of Health and Family Welfare has come out with this guideline that what should be the light in our overall hospital. So there are different areas in hospital where it starts from 1 lux to 300 lux, but it's very important for us to know that this is much different for operation theater in general, which is outside the table, that is 300, but on the table it should be from 2000 to 10,000, where we are using too high, where the recommended recommended lux is very low. This is very important. There should not be glare. In the operation table, on the operation table it should be zero glare. That is very important to understand. We all know what is lux per square meter. But it's interesting that how do you compare with the normal light? Sunset and sunrise is only 40 lux, where the brightest sunlight is 1,20,000, and we are using 1,70,000. And the moonlight is less than 1 lux, that is in Purnima, but in Amavasya it is 0.0001 lux. So that much low light is required. Age advances. After 30 years, you lose transparency as well as the amplitude of accommodation, and also you cannot perceive adequate contrast and focus. So more the age, you require more lux. And there are certain sources where we all know the latest one, which is LED, which is most recommended because of the minimum heat and a low power consumption and having a long life. Now various mounts are available from so many manufacturers, and we all know that according to the size of OT and the conveniency and the area of working, you can have different types of mounts. And out of this specification, as per the OT requirement, you have to go through, but there are 2 or 3 very important specifications, particularly the number of LED in that particular dome and the diameter of the dome. That will give you more shadowless light. 3 distinct specifications which I like to mention is about the color temperature Kelvin, which is from the darkest red to the darkest blue. So you can have an as natural light as possible, and the diameter of that field should be from 15 to 35 centimeter. And the illumination depth, like you are doing a TKR and the knee is flat, so knee comes up near the right and then it goes down. That way you should have some 80 centimeter to 180 centimeter type of a range where the focus should be there. So you have to go into technical detail of this. But what about the general? General, it should not be more than 600 lux, but very important is that there should be nothing glaring inside the whole operation theater. Regarding the scopies and IITVs, try to see the best contrast and do whatever you want to do with the monitor rather than keeping the light low. There are some accessories like sterile handles and remote controls and video camera and some protective covers. Now there are some handles available which is over the camera, and they are centric or it may be eccentric, so you can accordingly adjust. So in all, you have to have safety precautions like dependable ceiling mounts, standard cables, standard switches, standard stabilizers, MCBs, and minimum heat generation, and preferably the dome should be shock proof. There are some aids like forehead lights, and there are now retractors available with the inbuilt sort of a optic fiber attachment, so you can get some light inside the depth of that cavity. These things are available. And now in Ahmedabad we have got this particular portable chargeable light for the scopy, where you just charge it and you can give a light, and when it is attached with the optic fiber, you can have almost the same sort of illumination without using the main cable, and that is how you can see with the arthroscopy light. So this is a very good one, which is for the portable one. Particularly about the instruments, when you're talking about light, you have to avoid all shining instruments and you have to go for the dull finish. But if they are very much shining, just decrease the lux and you will be comfortable. This is a paper which says that you do not use such a white sponge because it increases the reflected light by 226 times. So it is 226%, that is too high. This paper says that endoscope supplies illuminance comparable to the surgical microscope. So both the things are good if you are using with a spine. And this is the paper which goes on telling so many critical components when you are using a surgical light, that the centering of the surgeon's immediate field and some illuminating wide and narrow field and high intensity, or somewhere how to get the best of the light in a penetrating sort of a area where there is a flap which is coming in between. And it says that brighter is not always merely better. So you have to be very careful that it should be soothing to the eye, and all your approach should be as nuanced as possible. So my idea of future light is that it should be smart and intelligent, it should be programmable as per the surgeon's choice and age, it should be voice activated controls for light as well as for the camera. There should be auto navigation based positioning. So the moment I change my head, the light also should change and I should be able to get it the best of the light on the operation field. Database record of the video for documentation where the camera is attached. Auto Kelvin control, and it should be a part of the integrated operation room system. And it should have an auto complaint. Now there are components available which is directly connected to the internet. So the light itself will send a message to the company that there is something wrong. So they just come and repair it. Now let us talk about the operation table. So in this operation table, I'm going to talk about the importance of the table, the positioning, the ideal table with specifications, specific features, some basic positions, accessories, and the special purpose OT tables, accessories, tailor-made, how our people have come out with an invention, relevant publications, and if you want to go for a table, how to explore, to look for, and then to decide, and my idea of future operation table. So the importance we all know is the most important part, and it is a phenomenal role in the quality of surgery. The versatility helps you in a big way, but it has to be a pre-operative planning that which way you are going to fix the table and get the position. Lack of accessories or faulty attachments may be the root cause of day one failure. So it makes a big role. I mean, it's very important for us. And there are so many modifications coming out in the market, so you have to look for that. And for the specialty or a special purpose OT, it is a major asset. So you have to take care of that with the trained staff and all the precautions. Now, proper position is important for the part of the anesthetic aspect and also to avoid problem with the or damage with the arteries or nerves. And you need to have an adequate exposure at the operative site, and it should be comfortable to the patient and also safe for the patient. The ideal standards is that you should be able to give position with the confidence. You should be able to capture all full range images. Maneuver should be easy. It should be efficiency, and the productivity should be the best. And it should be able to perform all type of orthopedic surgery, including anterior hip, shoulder, spine, and pelvis. So some of the basic specifications are there. Do not get so much confused or bothered. But you need to go for everything because each of your specialty requires different types of angles available and different types of positioning which is available. So you need to go into details of all these things. And there are some standard features of the table, like it may be electrical, hydraulic, or maybe manual or combination. Tables are eccentric as well as centric pillar. And they are controlled with a wire, wireless or Bluetooth, and there is a auto zero position availability. There is a floor lock which is manual or auto. You have to have radiolucent tabletops, and you should be compatible with C-arm, O-arm, as well as for all X-ray cassette holders. And all this material should be as best as possible. So you need to check all these things pre-operatively so that you know that the table is absolutely updated, and then you have to have all these attachments and necessary handy, including the manual, so that you can give best before you start the operation. Table is an instrument of surgery. It's a part of instrument because it's going to give you all the best results with the whatever the operations you have decided. Some of the very good accessories like silicone all supports and all straps and this thing you have to be very careful. There are some special purpose this type of operation tables where you can do with a translucent radiolucent areas. A special purpose we have to go with these tables where you have to go into detail of all these things. I'll take 1 or 2 minutes only now. For the subspecialty, there are so many different attachments which are available, so you need to go for all these things. There are tailor-made, like Dr. Sandeep, who has come out with this a simple solution with just a wooden part for the supracondylar pediatric fracture, and wonderfully is able to perform the surgery and to get the best of the IITV like this. So these are some good things, but in my practice, I have been very much helped by this particular simple wooden arm board, which I just put it there, and it helps in multiple ways. And there are some of the other facilities like a thigh support, which is very important, so look for that, particularly for the proximal femoral fracture. Now this is which I want to emphasize very importantly. We forget that the foot piece is in the center of the foot, which is not good because the alignment of the tibia is much posterior. So this type of foot piece you have to avoid and try to find out something which is in alignment with the tibia, so that when you rotate it does not go with the angulation or translation at the fracture site. And these are some of the best of the positions, and so many things are available in the market with all different types of, for the vascular, for the pelvic, and all these things where you get radiolucent things. This paper says about that how to avoid the pressure ulcers and other injuries, and how to take care of different aspects of the table. This paper says that the soft tissue injuries, particularly perineum and iatrogenic compartment, should be avoided, and these are the known documented complications of a traction table. And in hip arthrosis, they say if you go with a zero position, then you go from 10 or 15 degrees of tilt, that will minimize the perineal pressure. This is something which is the latest one in a COVID-19, where you use your local resources rather than referring the patient far away for the radiolucent tables. And in a arthroplasty, it doesn't make much difference as far as the direct entry approach, whether you use traction or a simple one. And for the lumbar, the in middle portion is very important that you can get a desired lumbar lordosis during surgery. And for the sleep similar episodes, they say the translucent radiolucent table is equivalent to the traction table. So take care of all these aspects with the anesthesia aspects, as well as for the iatrogenic problem, and as well as the avoidance of all the hazards. This is very important. Positioning problems can result in significant injuries and successful lawsuits. So you just cannot avoid that. I don't want to go into detail of this specification. You have to learn everything, and you have to see that it's a part of a pre-operative planning, that how you are going to take care of this. So wire ranges available, you find out, and better you ask your colleague that are you happy with that, or try to attend that particular operation and then decide that this is a table for me, and also take help of anesthesists as well as the chief staff, that whether all these things are available, and try to see that you purchase everything. Do not purchase part of it, because everything is very important and the training of the staff may be required, and you have to see that everything is safe as far as electrical and mechanical aspect is concerned. So this is the last slide, that my future orthopedic tables, it should be programmable, surgeon specific, position specific, fully automatic. It should be part of the integrated operation room system, internet connectivity for auto complaint and calibration, auto documentation of angles, tractions, force and light, everything should be digitalized, so that I know that how much traction was given or how much time was given. and auto positioning synchronized with the navigation system when we get a one touch, and it should be fully radiolucent. So I thank you very much for your kind attention and listening.